So that said, I will give the word to Jurgen in order to start a short introduction on the basics of plaque recognition. One final word, Jurgen. So this is an interactive webinar. So in case you have questions, please don't hesitate to use the Q&A or chat function in the Zoom app to ask questions, which we will try to address live during the next 90 minutes.
Okay. Yeah. Well, thank you, Joost. And I think that we go to the first slide here. And for image interpretation, we always start with recognizing a normal artery. Well, we put some histology on the left side, where you can see the intima, the media, and the adventitia of the histology. And you can appreciate that on the IVUS cross-section in the middle, you see the IVUS catheter, the bright part, what you see at 5 o'clock, that's the guide wire, what is attached to the IVUS catheter. Then the darker stuff in the middle, that's the lumen. And then we can recognize 3 layers, actually 2.5 layers. One, the intima, we can see the media, and we can see the leading edge, the inner side of the adventitia. Now the intima, that's dense, that's the inner side, and will appear as a gray layer between the media and the blood speckling. And we're talking about a normal intima in this case. And the media is made of homogeneous smooth muscle cells. And the key word is homogeneous, because in homogeneous material, which is quite regular, you will have no reflection of ultrasound. So that will stay black until the ultrasound beam reaches the leading edge, the inside of the adventitia, and that is composed of collagen. And because of difference, and that is a bit technical term of acoustic impedance, a huge difference, we have a lot of reflection, and that's why it appears white. And behind the adventitia, there is a lot of scattering and reflection, so the outside of the adventitia is falling away in the surroundings. So that's the normal artery, and I advise you to put that one on your spine, that you recognize that one, because that makes it easy to recognize the diseased one. And I think then here we have the diseased, and we put some plaques, different plaques phenotypes, and actually the plaques that you can see, that is about 93% of the plaques, type of plaques what you can find in your patients. And I always call this lesson 1 of image interpretation. If we start to the left, then we see a cross-section there. The top one is a still frame, the bottom one is the moving frame. And then you can recognize the IVUS catheter, you recognize the guide wire at 3 o'clock, and you can recognize the outside, the media, that dark line on the outside of the vessel. But now from 9 to 3 o'clock, you see a plaque. And if you compare that plaque with the density, the brightness outside, then you see that in general, this plaque is more dark than the outside. And then we call this fibrofatty or softer tissue. If we go to the middle part, then you see also the cross section. Now you see plaque from 12 o'clock to 5 o'clock. Now you see that this plaque is in general as bright as the surroundings, without a shadow, and that we call fibrous plaque. So if you compare the two, the left side and the right side on the moving screen, then you see that in the right side and in the left side, that the plaque, there is some motion in. It's a bit moving away. That means that it's rather soft, while the fibrous tissue stays in shape during the heartbeat. So this is more stiff plaque. If we go to the right part, well, there we see the ones that most of you already recognize from the first sight, from 9 o'clock to 3 o'clock. We see the plaque. It's as bright as the surroundings, but now we have a shadow, and a shadow that's typical for calcium. That means that most of the ultrasound signal is reflected by the calcium. What goes through find the calcium on its way back and will be reflected the other way around. So behind the calcium, we see no information behind the calcified plaque. And as you can see that also this calcium is quite stiff. And well, as you all know already, that calcium, that means you have to do some lesion preparation. So if we have the next, then I think that, yeah, then we have here the
program for today.
The program for today.
Yeah, so as mentioned, so as you've seen in the invite, the focus of today will be on plaque recognition in patients presenting with acute coronary syndrome. And this is something that is probably of growing interest. I mean, in most of our practices, the percentage of patients that present with ACS is growing, and at least in our side, it's around 65 to 70% at present. So this is a large group of a large part of our routine practice, and also something in which we actually focused on when we started studying the routine use of IVUS. And maybe this is one of the nice reference papers that you can use in your practice as a nice reference work in order to start to appreciate the different types of thrombus. And this is just in very brief. So on the left side, you see the case examples of the acute thrombus, subacute thrombus, organized thrombus, and plaque protrusion in patients, or thrombus protrusion in patients post-stenting. So the acute thrombus is characterized, as you can see, by the bright white appearance of the thrombus, virtually no signal attenuation. The subacute thrombus is characterized by more grayish appearance. You can see that in panels C and D, sometimes with a little bit attenuation, but typically not. But it's a really much more inhomogeneous aspect as compared to the organized and acute and organized thrombus. And on the right side, you see these black spots within the arterial wall that are typical for organized thrombus. They're typically attached to the vessel wall, and in some occasions have very mild signal attenuation, but mostly they don't, and they're sharply delineated. So those are the three types of thrombus that you can encounter when imaging patients in corporate lesions of ACS. And on the right side, obviously a example of a patient with a vessel that was just stented and shows signs of thrombus protrusion, which may happen, of course, if you inflate your stent at high pressures in a soft fatty plaque. That said, Jürgen, any comments, anything to add here?
Yes, because thrombus, that's a story apart, because thrombus is not plaque like I explained before. But thrombus is formed in the blood, and it's, as you know, a whole process. And what we found in this progress already, and that took some time, that we can recognize indeed three different stages of thrombus, and that is the acute thrombus, well, as you mentioned, then the stage subacute thrombus, and people, if I tell you the lines of Zahn in histology, then you will recognize that it's a subacute thrombus, a sort of in-between stage, and then the organized thrombus when the granulomes are trying to eat the thrombus, and that is quite homogeneous and a regular shape of tissue if you look at histology, and that's why it's black. It's can be quite challenging to study on the thrombus, but I think with this article that if you read that, and there's also some book chapters, then looking carefully and at ease, I'm sure that you will recognize part of thrombus, and STEMI and non-STEMI patients, those are the ones that you have the biggest chance to meet it.
Yep. All right, so first let's start with the first case.
Yes.
So this is a patient that we want to present to you. It's a, I think, female patient, 69 years old, active smoker, who presented with a STEMI, as you can see on the EKG ST segment elevation, mainly in the lateral leads, and that appeared to be correct. And this patient finally underwent the IVUS guided PCI of the circumflex. So this patient presented with a right coronary artery with some, I would say, some vasoconstriction, maybe some spasm due to the acute setting, LAD showing the same phenomenon, but then a large ostial circumflex with a complete, probably thrombotic occlusion in the proximal part. This patient was enrolled in the Spectrum trial, which is a prospective observational trial in which we want to study tissue characterization and primary PCI guidance using HD IVUS. So in very brief, prospective study, 200 patients that will go prospective, IVUS guided culprit lesion assessment. So before any intervention, we did an IVUS pullback, then guided our stenting by the use of these IVUS findings, and also did post PCI optimization using the high speed and high definition IVUS system. So also in this case, we started with doing a pullback in the circumflex, and that is what we're going to show to you live on the ACIST console.
Yeah. Well, that's we can make that the part on the right, we can make that bigger. Then I just for your orientation, remember it was easy to pass with a wire through this closed vessel, because you saw the vessel was closed with a wire, and then with the IVUS catheter they went in. So for the rest, nothing was done, no thrombectomy. And then we started in the distal circumflex, and there we see already, you recognize that now at 3 o'clock, some fibrous plaque. If we go moving more proximal, then I have a couple of spots what I want to put your attention to. And then if we go more proximal, then you see here, and if I put that in motion, then you see already some turbulent flow in there. And if we go even more proximal, then we see here in the lumen that's quite bright, and it looks like the appearance of an acute thrombus like you saw on the slides. However, this is not acute thrombus, this is non-moving blood, and you can compare it with spontaneous contrast recognizable in your left ventricle ultrasounds. And that makes it, and for ultrasound, non-moving blood and platelet aggregation, that is the first sign of thrombus, is the same. A lot of, it's completely inhomogeneous, so a lot of reflection. Only the difference between non-moving blood and acute thrombus is that this acute thrombus will be against the wall, and you see normal blood flow in between there. That's the difference, and that for ultrasound, it doesn't matter if you're non-moving blood or platelet aggregation, the first sign of thrombus. Well, non-moving blood here, that gives an indication that somewhere proximal, the IVUS catheter is occluding the vessel. That's why we do not have any flow. Now let's have a look if we can find the spot. And if we go more proximal, then we see already here, we see thrombus. It looks like if it's floating in the lumen. And you can see that the non-moving blood moves different than the thrombus. It's not floating because if we continue proximal, then it ends up that it's part of thrombus that it's attached to the wall. Thrombus, what you see, is always attached to the wall, and it looks like a sort of water plant in the middle of your lumen. So we can see here the thrombus, still non-moving blood, and that means if we go more proximal, then we see here also the subacute thrombus and the spot where it's occluding, where the IVUS catheter is occluding the vessel. And we see that there's more thrombus here, and here it's a whole region of subacute thrombus. I indicated in here, you can recognize it. It's brighter and darker in there, more homogeneous than platelet aggregation. It's in there, and now with two side branches, now you can see that because of two side branches, there is more flow because the blood can't stream through the side branches. And that is the difference between flow in a blood vessel and no flow in the blood vessel. So this is the part that you want to treat. That is the culprit part. Proximal, you can see some concentric plaque. And then at the end, we reach the bifurcation with the LED. And then because of the guiding catheter is quite selective, we end in the aorta.
Yeah, so I think this is a very nice demonstration on the different types of thrombus that you can encounter. So really distally, you see these homogeneous, nicely delineated pieces of thrombus that look like a organized thrombus. So if you go back to the briefly back to the IVUS, then this actually is derived from the part with the subacute thrombus, which is clear if you go a little bit more proximal. Here, see the thing that looks like organized thrombus.
Well, the organized thrombus, that is because you have to be careful. There is some drawing, there is reflection from it.
Yeah.
And the organized thrombus, you actually never find swimming loose in the lumen. It's always attached to the wall and it stays there. And you see around here, you see that the black part in the same shape of the vessel attached to the wall with a double layer in there. And that's the organized thrombus, because organizing always starts from the outside of the vessel where it's attached to the wall. So probably we find some organized thrombus also in here against the wall.
Yeah.
Yeah.
But what you can clearly appreciate is that in these parts with the subacute thrombus, Jurgen, I think that you tend to agree, is that it's always very difficult to see the vessel wall. These tissues are very actually extremely inhomogeneous. There's signal attenuation, and it's virtually impossible to see the vessel wall. Often, so in these cases, it's if you see this is with very high sensitivity and specificity a plaque rupture and subsequent thrombus. And that is something that I think is very good to appreciate. This is not a flushing artifact. It's just the fact that there's the catheter is occlusive and surrounded by loose tissue that is comprising the artery. So that said, we continued here with a aspiration thrombectomy, and then we repeated the IVUS. So that's also one part of the one of the critical reasons why we did the spectrum trial, just to assess what are the patients or what are the types of thrombus and lesions that might benefit, for instance, from thrombectomy or specific types of 2B3A inhibition. So these are data that will hopefully follow by the end of the year once we have analyzed the data.
Now you see here that now we also start in the distal circumflex, but now you see in this distal part that we have, although it's a bit brighter, but we see now a darker lumen, darker speckling, more homogeneous speckling, and that's indicating that we have flow if you compare it with the part before. That means that we have no occlusive IVUS catheter anymore. That means that we definitely removed some thrombus. There's still some there's still some organized thrombus in there, but if we go more close, then we see probably some lossy material. Here we have some fibrous fibrocalcific plaque. Now we can appreciate it better than when it was full with thrombus in there. And here we have still a minimal luminal area, and here around this that there is also some slow flow around the catheter, some turbulent flow in there, still plaque and a small lumen, and we can even appreciate here a small dissection. And here we're outside again. Now definitely that we have more lumen at the MLA. There is thrombus is removed. Some thrombus is still there, but definitely something is removed.
Yeah. So there's one question from one of the attendees asking whether our treatment strategy actually changes based on the time of thrombus that is present. Yeah, that's obviously the critical question that we, at least by observational study, will try to answer. We will have a wide array of different types of thrombus burden, and also a difference in treatment. So there will be operators who do a thrombectomy, some use pre-dilatation, some use direct stenting. So in the protocol, this treatment strategy was left to the operator's discretion. However, what we will do is we will computate a thrombus burden in all these vessels. We will look at the thrombus burden, and so the number of frames with thrombus and the type of thrombus present, and see how the individual treatment strategies, being either thrombectomy, a POSIS, a balloon, or a direct stenting approach, will affect the final outcome.
Yeah, and don't forget the medication that you give them afterwards. Or,
Absolutely. Yep.
Yeah. And there's another question: which imaging mode do you find most helpful for identifying thrombus? Well, we have three modes: classic, lumen, and silk. And we use, but not only for thrombus, but for all our IVUSs, we use the lumen mode always, because because we have several IVUS machines and we want to be comparable with everything. And then this one is comparable with what we see on the other IVUS machine without losing features of the 60 megahertz HCI. And if you experiment a little bit with that, you will actually find yourself that you will have a preference in there. But our preference is the lumen mode.
Yeah, that's correct.
Yeah.
Yeah, but of course, it's a matter of taste at the end. Yeah. The resolution will not change by changing the profile. You need to try it and see what you like the best. And in some cases, it may help to change the brightness or the contrast a little bit. That does more than changing the mode per se.
Yeah, I changed the brightness a little bit.
Yeah, Jurgen is showing it to you live now. So if you can go back to the back to the screen, you can see it.
See, there is one brightness part in here. Sometimes that happens also, that you have a sort of general, more darker picture, and then you can help that in here. Most of the time, if you start with a very dark picture that you see, I don't see anything, then try to flush or re-prepare your catheter outside the patient, because most of the time has to do with preparation.
Yep. All right, so back to the case. So in this case, the operator proceeded with the pre-dilatation with a 3.5 millimeter balloon, and then repeated the imaging again.
That's very good, because then after pre-dilatation, you can appreciate eventual So here we have the situation after the pre-dilatation. We're around this, in this region. So a large side branch distal. So you see still there is a lot of still good flow, but now we can appreciate more that this vessel was quite diseased, and that we also have some calcium in there. And so now we can see the sharp line of the superficial calcium from 6 to 12 o'clock with a minimal luminal area in here, and the middle end in here that we have, and yeah, and that we have here still some organized thrombus. Now we can appreciate it better because we have more flow in there. We can discriminate it from the darkness of the flow and the darkness of the thrombus attached to the wall. So this is there for some time with some subacute thrombus left in there. And again, also here we see something that I doubt a bit if it's subacute thrombus, can be also part of a hematoma after the pre-dilatation. Actually, we see a dissection in here. You can appreciate that with the blood speckling in here, that it goes behind the flap. Nevertheless, this gives the information for what we want to use, that we want to cover. Now, then the next step after your pre-dilatation is then to define what do we want to cover and what do we size. We didn't speak about any sizes before, because first we wanted to know what are we dealing with. So in this case, the thrombus, what are we going to do with it? Thrombectomy, check. pre-dilatation because it wasn't enough, then check. And now, if you're satisfied with your pre-dilatation, then it's time for to do your measurements. And let's start proximal. That's of course all up to you where you start. So you find a good landing zone, preferably. Well, preferably, and I say preferably, you want to have one with less than 50% plaque burden. And well, let's see if this is a nice one in here. And you see that I keep the picture moving. That can help you to define where is your border of your lumen and your media. Then I will make another area that's in there. Oh, that's in there. So I can correct it later on. By the way, normally I do this with a touch screen. The touch screen is actually I like very much in this case, but now for the time being, well, what you see here then, even because I went a little bit outside, but still we have a plaque burden of 40%. So this is a good landing zone. And for everyone, for the mid, what I call the mid, and I do this already for many, many years, that I said, please guys, size on your lumen. Forget a bit the media, especially in here. If we have 40%, then some old studies, and that one is even before the IVUS, that was from Mr. Glakov, and later on by Hermiller, who demonstrated the remodeling with IVUS. Below the 50%, especially with 40%, then your vessel size is first increasing or stays the same. So that you can consider the lumen size, and your lumen size is increasing or stays the same like the original vessel size. This goes all outside. So that means that you can consider your lumen as the original vessel size in this case. Now, what we see here, you get for free the smallest diameter and the tallest diameter. So we have here 4.2 millimeter by 3.9, or so 3.9 millimeter. This is the lumen by 3.19. So that indicates already that maybe we need a 4 millimeter, but now we have to go to and find another landing zone. This is what we want to cover. There is we passed the calcium, and here also a nice landing zone. Again, you can do this with your finger on the screen. And already, I think you made an estimation for yourself looking at the former. So again, here, 40% plaque burden, which is good. And a diameter 4.17, that's the white part, that's the lumen by 3.5. Well, then the next part is then the length. I hope that in future because that automatically the machine will calculate the length between the two bookmarks. That's possible, but now what we put then, we take the length and we take the bookmark, and then we bring the length to the other bookmark, and there we have the length of the stent that we need, 24 millimeters. And I think Joost, you will agree that you would place a 4.0 stent in there.
Yes, absolutely.
Yeah.
So in this case, the operator decided to use a 429 millimeter DES based on the availability of the stent size of this 4.0 device, and then we repeated the pullback.
Yeah.
So
that's
the good thing you will, so there's another question, how important is identification of the rupture plug location? I think it is very important, as you will see in cases that we present you later on. Sometimes the plug rupture is not at a spot where you think it is based on the angio alone. Plus, it will help you to identify where the lesion is, because at the end you want to stand the lesion and the stenosis and not the thrombus. because sometimes thrombus may really protrude into the distal territories of the artery, and then obviously stenting is not the therapy, should not be the therapy of choice. You need to stent the lesion and not the thrombus, at least as far as that is feasible. So in our opinion, the identification of the cold protrusion and the rupture plaque is important and is one of the key benefits of using imaging.
Yeah.
You've seen we did a lot of pullbacks. The good thing of using these high definition IVUS pullbacks is that it also has a high pullback speed. So it's 2.5 millimeter per second. That really allows you to do very quick pullbacks in patients with also in unstable conditions. Plus, the next advantage is that the amount of contrast that you need is actually very limited. So in between these pullbacks and steps, we virtually use no contrast.
Yeah, you make less films.
Absolutely.
Yeah.
Yeah.
Well, this is after the stent. Let's see if the stent size was a bit according to the measurements. The choice, I think the choice was good. So we start moving. There is this side branch, and the operator places stent. Yeah, you see it's just halfway over the side branch. Here's a stent. You can recognize them by the small dots around. And what you also can appreciate that the stent struts here are against the lumen wall. So we have a good apposition and a good lumen. So if we move in here, then we see at the spot where we had some thrombus, that the stent was a bit expected a bit under deployed, but maybe it's not that bad. No, it's not that bad. What we see that we have a good apposition there. Now, what we appreciate here at 12 o'clock, and I put that in motion. Here we see some thrombus protrusion in there. And that is something what you always can expect after stenting thrombus, especially if you could not remove much, that you will have some thrombus protrusion in there. There is a difference with tissue protrusion. Sometimes soft tissue can also protrude to your stent struts, and then you will find the protrusion only between two stent struts. Thrombus tends to dig your stent struts into the thrombus, like here. It's over a couple of stent struts. It comes from behind the stent. And well, before you say, well, then we put another balloon in, and then we push the thrombus back. I think that is a dream that everyone may have, but it will not work, because the reason why the thrombus is there, that is because there's no room for the thrombus behind the stent struts. So if it's a lot of thrombus, it will resolve, but then probably you want to do something with the post medication in there. So far that we have a good lumen, we have some thrombus protrusion, and then we look at the edges, and we look for edge sections. Here's the stent struts, and you see I go up and down to see if I see disruptions in the plaque. Proximal, where we are now, we didn't see that, and distal also, you see that we have no disruptions. We have a little overlap with this side branch, but that will not spoil the party. And the last thing what you can do is, and yeah, you see here that is the part of the stent. So this of the thrombus, that the stent is have some indentation. So what you can do for the minimal luminal area, that's a little bit what we call the carpet nasal, and then I'm only go for the lumen. Well, there we see 9.
Yeah, so minimal stent area of 9 is
9 square millimeters, and it will be, I think, yeah, less than 10% from your references.
Yeah. So in brief, remember those. So the optimal stenting criteria: a plaque burden at the edge is less than 50%. Jurgen nicely alluded to that already in the sizing part of the pullback. The second thing is to have optimal stent expansion. That's perhaps also the most important one, which can be identified as being either a minimal stent area larger than 5 or a minimal stent area, which is at least 90% of the distal reference segment. So those to those criteria we managed. And the third part is that you do not want to have any submedial edge dissections extending over a length of at least 3 millimeters. So those three criteria we at least met in this case. So this case would obviously have qualified as optimal stenting. In case there's another question, what do you recommend? How to calculate the percentage of stenosis in IVUS? So this is an interesting question. With QCA, you get that immediately. And with IVUS, you can get the exact same thing. So maybe Jurgen can demonstrate that to you in the next case when we'll do the pre-PCI and the sizing algorithm. We will demonstrate to you. But in brief, the key trick is to put a lumen marker distally in a healthy reference segment, mark that as reference, and then you go to your site of minimal lumen area, which you can identify by eyeballing quite accurately, we've recently discovered, and you get your percentage area stenosis. All right, so case 2, if you go back to the slides, we'll present you case 2.
Then I go to,
which is a 70-year-old male patient, also active smoker, presenting also with a STEMI. Time of onset of chest pain is not clear. I'll have to skip this. So by the way, this was the final result of the previous case. Yeah, so then case 2, so active smoker, 70-year-old, presenting with a STEMI, again, ST segment elevation in the inferior leads in this case, which fitted with a occlusion of the right coronary artery, which we'll show to you. So this is a right dominant coronary artery system with a left side, some diffuse disease, but no clear or focal significant lesions. Thrombotic subtotal lesion in the right coronary artery, and as some of you might have noticed, you see this small dash of contrast in the right coronary sinus, which was the result of probably a osteal dissection in which there was a small dissection of the aortic root due to the guiding catheter manipulation. So this was just as a small side note. So also this patient was enrolled in the Spectrum trial, and obviously here as well, first step, IVUS.
Yes, there you see. And if you look at the screen, can we go back the angio screen once more? Yeah, then you can recognize below, you see a marker at what indicates the tip of the catheter, and then proximal from that marker, you see the indication of the IVUS probe, and that indicates where you start with your IVUS. Yes, that's the one. Yeah.
Yeah, people don't see the mouse, but you see the two distal markers. Let's say at 6 o'clock, the one most to the left is the lens of the imaging catheter. So that's where the IVUS actually starts to loop where the crystal of the IVUS is. And what you also can see that in all of these pullbacks, the first pullback, we always start distal in the vessel. Yes. So never start your pullback in the plaque or in the thrombus. Use live imaging when you advance the catheter so you know where you start the pullback. And the basic principle is, specifically for the first pullback, always start in a healthy, different distal reference segment.
If there is a healthy segment.
Obviously, obviously.
Yeah. Well, here we started indeed in the distal right coronary artery. I will brighten up the image a little bit for you. Yes. So what we see here, that we have indeed a more or less healthy segment. So we see some intimal thickening in there, huge lumen, and then we go proximal. So still a normal 3-layered appearance, maybe a bit intimal thickening, but this is what we call healthy. And if we go more proximal, then here we get some plaque. We have some mixed plaque. We recognize some calcified plaque in there, some softer tissue. And here in the mid RCA, we see more plaque, but what we also see is that there is a line, you see a double layer with thrombus upon this. Yeah, so we have here subacute thrombus. We continue, Here's also some calcification. And more proximally, we have a huge region of thrombus, mostly subacute, into the lumen. So if we go more proximal, then we have here again a thicker lumen, a darker lumen. It can be also a thicker media in here. That's and I was looking for a plaque rupture. Here we have still a normal vessel. We couldn't see the plaque rupture in here yet. Some thrombus in has some calcium. Here you can recognize also a bit the slower flow, the turbulent flow in there. But here we see in the mid RCA a huge thrombotic lesion with a small lumen. Nevertheless, the IVUS catheter is not occlusive, so that's why we have still flow behind in there.
Yeah.
Yeah.
So Jurgen, maybe for the sake of demonstration, now
Yes.
suppose this is the side of the MLA. So how would you measure the significance of the lesion? So as we mentioned, we typically find the put a reference on in a distal healthy reference segment.
Yeah, like this in here.
Yeah.
Here we can make a reference. So what we do, we measure the lumen, and because I'm a lumen measurer, that's already. So and especially in this healthy segment, and forgive me if it's that I'm a little bit sometimes a bit trembling in there. So then here we have the lumen, 11.38 square millimeters. We keep that in mind because in this case, what should be done in here, and what I didn't find yet in the system, but definitely in future it will come, that you can make this as your reference segment. So if you indicate that as a reference segment now we keep it in mind, 11.38, then we go to the smallest lumen. So we find the smallest lumen. It's between the carpenter's eye, like we say in the Netherlands, and that smallest lumen is in the thrombotic lesion around here. I will draw it for you.
This is just obviously for the sake of demonstration.
Normally,
but the critical thing, and Jurgen said I'm a lumen man, but I think what is important is that you put your reference segment in a healthy part where the lumen and the vessel area should be nearly identical. Plus, what is important is that at the site of the minimal lumen area, like here, you cannot identify the vessel.
Exactly.
And if you can already identify it, and there's a huge plaque volume, this vessel will be dilated anyhow, so it will not be a representative vessel area.
Absolutely.
So in this case, it's quite easy. You would say 1.7 divided by 13 is around 87% percentage area stenosis. So this is something that is very easy to computate, and the newer versions of the system will integrate that in a AI approach of the lesion. So that, sorry.
What you said, the minimal luminal area is for stent sizing the least interesting.
Absolutely.
Absolutely.
But
don't bother any time for that.
Jurgen, that's a very important comment, and I fully agree to that. The minimal luminal area per se has no meaning. But it does have a meaning if you do an IVUS pullback in patients with intermediate lesions, and you want to make a, let's say, thought through adjudication of the severity of the lesion. So you don't have FFR, you know eyeballing is not reliable. You do a pullback and you find the plaque burden as percentage area stenosis that is above 75%. Then the likelihood that this lesion is significant is extremely high. This correlates nearly 100% to FFR pullbacks, and this also is a proven predictor of poor outcome in national history studies like Prospect. So that's an important criteria for lesion severity assessment.
So
okido.
Yeah.
In this case, we continued. So this operator here decided, well, there's not much calcium. This is a STEMI. I want to do as little maneuvering as possible. And I use this first pullback to size my stent and pursue with direct stenting. So maybe we can use the distal measurement you already made, Jürgen.
Yeah, that was, oh, sorry, that was I have to
Otherwise,
go.
we redo
Yeah,
it. That's no problem.
I go back to the former one. It's there, but I was already a bit, I think, I'm afraid, ahead on that. So we have here our measurement.
Yep.
So that is 4.0.
Yeah.
Yeah, the diameter. So that is, and if we find, well, this is our lumen, and then we have to find the landing zone. And I think this is also a nice landing zone. And you see that the vessel is so big that it's getting a bit out of range. And also now we talk about it, this is 60 megahertz. Nevertheless, although it has a broadband, that also you have lower frequencies that contribute to the imaging, that's still bigger vessels, the farther away that you will lose some signal. And also here the depth setting could have been a bit better. But fortunately, we can see the lumen still. So let's make a measurement. We take the lumen in here, and well, if you want, well, just for the sake of plaque burden, I go a bit, and you see it's not really that reliable yet because I can't see the whole complete thing. But then in here, yeah, 37. And we have here 5.1, yes, 5.1, and then
times 4.0, yeah.
Yeah, times 4.0, have 5.1, and then we have, yeah, so, and then the length, oh, this one, I had to hold the stuff, I was too fast, yeah, there we have, so that's nice. You throw it away, and then you can fine tune it by grabbing the triangle and bring it where you want, and that is not in the middle luminal area because that is what we want to cover, but we want to go all the way to our landing zone.
Yeah,
and that is around here. 45 millimeters. What did they do?
Yeah, in this case, the operator opted for a 4038, which was at that time the longest version of the Firehawk stent we had available, and which we needed to use within this trial.
He had some playroom actually.
Yeah, but what is also important, so we picked here a 40. You may wonder, well, what do you use for stent sizing? Use the distal areas, the proximal areas. Obviously, in this right coronary artery, there are usually no large side branches, so the proximal and distal areas should be nearly identical. But in cases where you have a lot of side branches, like in the mid-LID, where the sizing can change significantly if you have long lesions with larger diameters proximal and smaller diameters distally, the recommendation is to use the distal lumen to decide on stent size, and then post-dilate or operate a little bit proximally.
Yeah.
So also here we, or at least the operator here, used a 4038 stent, and then per protocol repeated the IVUS.
Yeah. Then there we go. Now it's time to do it. No, I was a bit too fast. So here we have the normal vessel again in the distal right, and then we're going to see the stent. Well, we see here the stent, and you see that we have the stent stretch, we have some plaque there behind, and if you compare it, then more proximal, the stent is a bit bigger, but nevertheless everything is against the plaque. Don't bother about the burden behind that, it's all behind the fence. And then we had a bit proximal, there we have a huge region of thrombus protrusion, and that is something that you may expect if we see this enormous amount of thrombus that we had to cover
in large vessels, particularly.
In large vessels, yes. So and then here we have the stent well opposed, more proximal, and then we end in the proximal reference in there. So in the meantime, we already saw the thrombus protrusion. We in the meantime quickly looked at Edge sections, proximal, we don't see one. Distal, that's the one that that can play a part, also not in here. And that's why I would understand that you would be, well, you tend maybe to post dilate on the distal edge, but you don't want to go outside. So I would fully understand that the operator would leave this. But what was done, they were a bit concerned about the thrombus protrusion.
Yeah. So this is a nice demonstration on how you could use the imaging to look actually at what you did. So this is a 4-0 stent, and if you look at the distal edge, and you can see that this actually is a stent that is absolutely not that did not manage to reach the 4-0 criterion. Maybe if you draw a short line length measurement, you can demonstrate that. And this is when you just land in the plaque, because this is what happened. The stent ends just at the distal part of the plaque. You can see that there is some 20 to 30% underexpansion based on the at least manufacturer's expansion areas. So this is a stent with without post dilation. This is what you get if you put a 4-0 stent in a fibrotic lesion or a fibrotic part of the vessel. Then you will get some form of underexpansion. So underexpansion is not just limited to calcified lesions; it's also linked to fibrotic tissue. And this is, I think, a very nice demonstration, irrespective of the fact that this was a STEMI patient, on how stents look like. And this also illustrates you that in this case, it's a 4-0 stent. So you will have an area of 8.1, which is well above the threshold of 5 millimeters. But now suppose you have a 2.5 millimeter stent with 70% expansion, then your areas may quickly start drop below 4 millimeters. So this, I think, is why also in smaller vessels, the benefit of IVUS, on let's say how the benefit of IVUS can be nicely demonstrated, at least conceptually. But in this case, the operator was afraid of the thrombus. And if you go back to the part where the thrombus is, you can see one nice thing now, because the thrombus is pushed aside. In many occasions, you can actually see the vessel wall. And I think here, if you go to the largest part where the probably biggest positive remodeling was, if you would measure that, you would measure around 5 to 6 millimeters. Maybe you can just do that for the
biggest one in here.
Yeah, where you can see the vessel wall.
This one. Then
we obviously never do that. Here, you can see it. Here you can see it.
Here we see.
Yeah.
Here we see the vessel wall. Now let's see what is.
If you go from 11 to 5 o'clock, for instance.
Then, oh, sorry, I was a bit.
And voila. So this is 6.2 millimeters. So you would say, why the hell do you do this? Because this is a positively remodeled vessel. The stent is nicely expanded. Well, the correct answer is you shouldn't.
You shouldn't.
However, we do this to illustrate you that also in thorax centers, sometimes peculiar things happen. And in this case, the operator decided to post dilate the stent with a 6 millimeter balloon in order to, I don't know, increase the area or to get rid of the thrombus. But at least after the 6 millimeter balloon inflation, a repeat IVUS was made to demonstrate you the final result.
So we have
remember the minimal stent area was, I think, we didn't measure it, but I think it was around 8.
Yeah, about 8 was it was distal. That was around here. And you see that nothing changed here because he didn't go.
Yeah, so he didn't touch the distal part of the vessel.
See, that's will be. But now we're going to look what happened with the thrombus. So here we have the calcium, we have still here we see thrombus protrusion. You can see that at 4 o'clock. So I will brighten it up a little bit for you. Here it is, and I will put it in motion. Now you can see it. Here's the speckling of the lumen. Here you see that the stent struts are dug in the thrombus. So this is still thrombus protrusion, but you also see that the biggest part of the thrombus seems to have disappeared. And normally, well, what we said, well, you can try to push the thrombus back. The reason is that there is no room for the thrombus, but there is also another spot in there, and that we will demonstrate you after we show you the final result on angiogram. So far, so good. Less thrombus, there is pertusion, there is a larger lumen in the stent. So everyone seemed to be happy. So this is the last result after that.
Yeah, so here
And
we
then-
didn't measure, but the minimal stent area went from 8.1 to 9.3.
Yeah.
If you go to the slides again, we'll show the final angiogram. This patient actually had no reflow after the additional balloon dilatation, but which then recovered after the after some nitrates. Here you see the 6.0 balloon, the pullback you've just seen, and this is the final angiogram.
And look at distal.
Yeah, showing you a nice TME3 flow. However, you see some thrombus in the distal part of the posterolateral branch, with actually a stop at the distal part, right, Jürgen? That was what you were referring to. You see the RDP coming up nicely, but then the posterolateral branch stops at 3 o'clock on the screen.
In the angiogram pre-procedure.
No, that's correct. So probably this is where the thrombus dislodged, and after some integralin and nitrates, the case was concluded with a TME3 flow, but the blush that was suboptimal. So far, case number 2. Case number 3, if we go back to the slides, is a male patient of 70 years old. Also smoker, but in this case a history of AFib and 3 PCIs of the circumflex and obtuse marginal, who presented now again with a STEMI with ST segment elevation in the anterior leads, ST segment depression inferior. And this patient then had a angiogram in which we found a left dominant system with diffuse disease in a small right, a patent left main and circumflex, a occlusion actually of the stent in the obtuse marginal branch, and as you can see in the right panel, a subtotal lesion in the mid part of the LAD. And now it perhaps gets interesting, because now you have a case in which you have a left dominant system, you have ST segment elevation anterior, you have somebody with an old stent that is now totally occluded, and there's no clear thrombus. There's a subtotal lesion. But what is the culprit? Is it the circumflex or the LAD? And in these cases, the use of intravascular imaging can become particularly appealing. And maybe this is also an answer to the question, how important is identification of the ruptured plaque? Well, we think it is in this case because you identify the culprit. And the second, what I find a very nice illustration of how important this is patients that present with out-of-hospital cardiac arrest and multiple intermediate lesions. If there is no thrombus or no plaque rupture and there's no significant disease, these patients need further workup for any type of cardiomyopathies or intoxications, etc. But in case you do find a very mild plaque that you would have booked as mild luminal irregularities, but if you do your IVUS or OCT and find a erosion or plaque rupture, you have a diagnosis, and this makes it a significant difference for the patient's future life with respect to dual antiplatelet therapy, ICDs, etc. So identification of a culprit lesion, at least in my perspective, is something that is important. That is a small sidestep. So we proceeded here with an IVUS of the LAD, and maybe Jürgen can show that to us.
Yes. So what you saw quickly on the slide that there was sizing with question mark.
Yep.
And well, I'm going to explain you why we put it in there. So we started the pullback in, and I will brighten it up for you a bit in here. So we start in the distal LAD, and then we see a normal vessel. Is it normal? Let's see. If we see here, then you may see that what you see that your intima is quite bright, as if it is maybe fibrous plaque. But it has nothing to do with fibrous plaque. What we see here is that we have, and we can even appreciate it better here, that we have here a spasm. Remember that if your vessel have an original size and you get spastic, that your intima layer, had the mass of the intima layer, the volume of the intima layer stays the same, only it's compressed by there, and then you get a brighter intima in there in a normal vessel. And on a certain point, you see that there will be a jump in caliber where we get out of the spasm. Or if you give nitrates, you can even see it maybe on the spot that your vessel gets larger. So here we have this region that we say, well, it's normal, but it's highly suspected because of this for spasm. It's also quite small. Here we see the mid-LED, which is diseased. The mid-LED is diseased. We have a lot of soft tissue, fibrous tissue, and what we're going to see also calcified tissue in there. On the other hand, it's a lot of calcium. You can see in here even the napkin ring of calcium in there. Here we may have, and then this helps, the putting in motion, it helps that maybe we also see some thrombus in here. We see the double layer in there, that there is some subacute thrombus, especially in this region. A lot of calcium in there. And then we go to the proximal LED, the part in here, what you see here, this is a diagonal branch. And then you would see, well, we saw also another branch, a septal branch in there. Well, how can you discriminate it? Well, in septal branches, it's very rare that you can find plaque, but in diagonal branches, they have plaque that has something to do with the shear stress and the angle from where diagonal branches emerges. Here we see a napkin ring of calcium. We keep that a little bit in mind for a minimal luminal area. And also here, a lot of calcium, more than 180 degrees. And then we reach the ostium of the LED, and what we see there. And if you see my cursor at around 1 o'clock, there we see a plaque rupture. And you see the plaque rupture, you see the fibrous cap in there, it's broken, and there is some cavity in there. I'm going to see if I can make it a little bit more clear for you. Yeah, here it's even more clear. You see the broken fibrous cap, and the cavity, the empty cavity, which where is free blood in there and in here. So we have here a ruptured plaque rupture at the ostium of the LED, and the ostium, and here we have the bifurcation with the circumflex, and then we go to the left main, and also the left main is diseased, even with some sluggish flow, and here we are reaching the aorta. Well, that calls for another strategy, I think.
Yeah, so this is, I think, again, a nice demonstration on how IVUS could potentially change the strategy, because we know that in patients presenting with STEMI, 20 to 30% may arise from patients with thrombus on calcified nodules or lesions. But in this case, there was no clear thrombus, right?
Not clear, a little bit maybe, but it's not that we say, well, that's a real thrombotic lesion.
Yeah, so that makes the life sometimes difficult. Yeah. But again, we have a patient with ST segment elevation anterior. We have a very tight calcified lesion. And we have a ruptured plaque in the proximal LED that is non-thrombotic, non-luminal obstructive, and it is questionable whether that was the culprit of this STEMI or not. So that is left open. But in this case, the operator decided to continue with the pre-dilatation and then proceeded with stenting with a 3033 stent. And then did post-dilatation with a 3.5 NC balloon. So 3 consecutive steps that we typically don't recommend, because specifically for these highly calcified lesions, we recommend to repeat the imaging after the pre-dilatation in order to ensure that the calcified lesion was at least the calcium was fractured in order to achieve a proper stent expansion. That in this case was not the case, and also with a 33 stent, only the mid part of the lesion was covered. And that's quite interesting. So the operator was quite convenient. The balloon expanded nicely, stenting, post-dilatation with a 3.5 point C and C, and then repeated the IVUS. And that's the next pullback we want to show you.
This one, not well. This is so. Well, I just show you. This is the guiding catheter. They started to do that, but they said, well, we were too early. So then this one. Oh, sorry. Yeah, there we are. So we started now in the mid LED. Well, just the last part, yeah, the mid LED. And then if we go more proximal, there we have the stent struts. Have we just quickly have a look if we see already an edge section? Yeah, maybe a very small one in here, but that is subintimal. It's not attaching the media. But let's see what happened if he was in luck or not. Now, what we see is still a lot of plaque, but we have to measure behind the strut. Here is the calcium.
Yeah, and also the side probably where the lumen is the smallest. So this is what we call the minimal stent area.
Yeah.
Maybe draw a short circle.
I will make a short circle. See, you see that it hardly gave way. So that means that he implanted the stent in a napkin ring of calcium. We have 4.1, what is for this big vessel that we have actually, too small. And you see, well, normally I would say you can push with your whole family against this. You'll never get this bigger because you have this big resistance of this napkin ring of calcium in there. And if we go more proximal, then you see the size of the stent. Also here, there's still calcium in there. And then more proximal, also here we have an underdeployed stent. What was the size of the stent?
The stent was a 3033 millimeter DES. And this is a beautiful example on how you can use imaging but not use it properly. Because in this case, there was several things. I think what we try to demonstrate all the time is take it step by step. Look at the lesion. In this case, we did look. So there was a napkin ring of calcium 360 degrees, which is one of the criteria for heavy calcification. There was also a length of calcium 10 to 15 millimeters of length. Now, what we learned is that that is a independent predictor of stent underexpansion. So all these criteria mandate proper lesion preparation. And if you start with a trio balloon, which could be a strategy, at least you should repeat the imaging. And in case there is a persistent napkin ring of calcium, you need to think of other ways: cutting balloons, scoring balloons, shockwave, diamondback, etc. But which could have been an option in this case, in which there was virtually no thrombus. But yet the operator here decided to continue with stenting, even post-dilated with a 3.5 balloon. But as Jurgen mentioned, once the stent is in and there is still a napkin ring of calcium behind it, you can push as much as you want with non-compliant balloon, but that typically doesn't work. And also shockwave, as we just recently published in Euro Intervention, may be effective, but is not effective in 50% of the cases, although it's a very expensive technology. So if you would have avoided this upfront, you would have achieved a better stent expansion. The edges, as you've seen, and maybe we can take another look at the edges, are also suboptimal. The stent was too short.
Yeah, because what
starting already distally.
Let's first distally, because then we show the nicest thing.
You see the stent here, and the ending in the middle of a eccentric plaque.
Yeah, let's measure this one. See, that's, and we go for the plaque burden. The plaque burden you always measure in one cross section. That's different from, that has nothing to do with stenosis. This is plaque burden. So if we measure this, you see that I'm doing this honestly. Then we have 56%, more than 50%. Plaque burden could have been better.
Yep.
So,
And you
it's-
might argue, well, the area distal is 4.7, your minimal stent area is 4.1, that is 87% stent expansion. Well, that I have to say is from a definition perspective perhaps correct,
yeah.
but this definition assumes that your landing zone distally or your distal reference segment is a healthy segment in which the plaque burden is less than 50 and preferentially less than 30%. So in this case, the plaque burden was almost 60%. And using a lumen reference area in an area with a plaque burden of almost 60%, yeah, that does not make sense. So if you measure your stent area, use your eyeballing, use common sense, and then do your assessment before you come to any conclusions.
Yeah, and of course you can have situations then in a diabetic patient that you everywhere you have plaque burden.
Absolutely.
And then you have to choose. Yeah, then you need to choose, and then you define because you're the doctor, you know your patient what he or she needs, and then you define for your acceptable lumen, and that is the world is not always ideal, but in this case I think that yeah. Well, if I may say, big steps quickly at home.
Yeah.
Yeah.
Okay,
Yeah.
good. One final case we want to show you
This
is case number 4.
Yes, number 4.
This is interesting. It's a younger patient, somebody of 50-year-old male patient,
6'2",
smoking and obesity.
Oh, gee, yeah.
Maybe we can show the slides. Yep, 50-year-old male, smoking, obesity, also presented with a STEMI with ST segment elevation anterior. And then this was the angiogram, again, a right dominant system with a lesion in the proximal right. Not too much backflow of the catheter, so it's not really clear, at least to us who reviewed this case offline post hoc, whether this was spasm or a lesion. But then obviously the interesting part was in the LAD. The left main and the circumflex actually look nice, but in the LAD you see this inhomogeneous tight aspect of this of a lesion subtotally in the proximal part of the LAD. And also here, the operator did a first pullback, and you've by now seen multiple types of thrombus and lesions you may encounter in a acute coronary syndrome. But this is another one, which you have not seen yet, at least not in this webinar. So maybe Jürgen, take it away.
Yeah, then we start. We start in the distal LAD, which just there we are. We start in distal LAD with almost normal vessel. So if we go more proximal, we get in the mid, and there we see the plaque, and you can see mixed plaque. There's some calcium, fibrous, fibrofatty. So far, no thrombus, and it stays the mixed plaque, goes to fibrofatty, and you see so far is what you can expect, the plaques, but then.
So far everything good.
Eccentric,
stable disease.
The stable disease, it's the disease what you may expect in this patient. But then here, look at this, what we see here, and I'll let it run for you for a couple of moments, that we put this on play, and suddenly you see it gets a sort of bright cap. And on this bright cap, if we go a little bit back, then we see that the bright cap is compressing the media. So what we see here, that we are dealing with a submedial hematoma. And in here, in the submedial hematoma, there is non-moving blood. Remember that for the first case that we had it in the lumen. Now we have this in a false lumen. The blood is there, can't go further away, and is compressing the media, and thus the true lumen. So if we go further, then we see that there is a side branch. Side branch always goes in true lumen, and we see a false lumen with non-moving blood. And here we have a compressed lumen near a side branch. There's a wire in the vessel, and then we have a huge hematoma filled with now slowly moving blood. The blood is trapped. And then here you can appreciate, here's the media, and outside the media, between the media and the adventitia, the vessel is blowing up. So we have a So we have a submedial submedial hematoma or dissection. This is what you expect often with patients with a spontaneous dissection. And spontaneous dissection can be either that you can have the valsalva rupture in there that makes this hematoma, or there can be a rupture, a broken intima media, more proximal, that you have this this compressing hematoma in there. So if we continue there, then yeah, it looks like a spontaneous dissection. That is what we also wrote in our report with a question mark, because often with this age, what was the age of the patient?
50.
50, a male patient with a plaque, it would be very unlikely or rare that you will find a spontaneous dissection in there. But nevertheless, it's possible and we have to deal with it. So we have still the plaque, we have in the lumen here, we have the calcium, we have the compressed lumen due to the hematoma, and it all goes all the way to the bifurcation. You see, we have no thrombus in here. This is slowly moving blood into a hematoma. So here we see the media, true lumen with the IVUS in there, and then the blown up adventitia. So there we go, and the dissection extends, and you can, if you follow the media in there, you can still see the extends till we have the bifurcation with the circumflex and with the flow divider there. And then I got a bit suspicious, and that makes, and you see we have two wires in there, that makes it a bit difficult. So what happened? Did we make a dissection that it was iatrogene? I was not sure about this region there. The two wires didn't help. And if I remember the angiogram, the middle angiogram before, then I saw that the guiding catheter was quite deep and hitting the flow divider of the bifurcation. But nevertheless, I cannot see really an opening in there. So we kept it in the middle, spontaneous dissection, rare, but also possible iatrogene because of the guiding bumping against the flow divider. But nevertheless, we have to deal with it.
Yep.
So
I think, so in summary, hematomas can be appreciated very nicely, both on IVUS as well on OCT. They can be derived from spontaneous coronary artery dissections, which can be divided into either a intimal or a submedial rupture, either proximal or distal at the site of the hematoma. It can be a spontaneous hematoma. So those are cases with a hematoma without dissection flaps. Yeah. It can be secondary to a plaque rupture, but as Jurgen mentioned, this is extremely rare. But in this case, it could have been the case. But at least it was present. Yeah. Or finally, it could be, let's say, originated from a iatrogenic dissection or a catheter that jumped into the roof of a coronary and thereby ruptured the intima of the media and thereby created the hematoma. So that said, this indeed is a large hematoma, but also underlying plaque. So this had to be treated. This patient was unstable and also in this case received direct stenting with a 3.5 38 DES. If you look at the slides, a 3.13 DES and underwent some post-dilatation with a 3.5 4 millimeter NC balloon. And what you can appreciate is that the operator in this case probably also led by the IVUS and the fact that the left main and circumflex were nice and patent to land his or her stent at the ostium of the LAD. Yeah. So this is obviously something that you could argue, well, would you have stented to until the left main or just up until the ostium of the LAD? In this case, there was no plaque in the carina, so the operator took his chances and tried to land the stent just at the ostium of the LAD, which was based on the IVUS, theoretically possible, but yeah, as we know, is also very difficult. So yeah, that was done, and maybe we can show the
I've one additional thing. If this happens to you, if you see this, keep your wits together. That don't make it that this is not your vessel size.
Yep.
That you, in this case, that you say, well, we have, it looks like a huge vessel, but it's nothing to do with the vessel. It's a blowing up adventitia. That if you choose a landing zone, choose this one and forget the size of that, because if you cover the dissection at the end, the size of the adventitia comes back in there. There can be multiple causes for the submedial dissection. Submedial dissection with the adventitia, they tend to blow up. And that don't let that influence your stent size. So 6 did a lot of pullbacks, but we had number 6 to see what they actually did.
So obviously imaging can be used to guide your stent sizing and should be used to guide stent sizing, but should be always put into perspective to the clinical scenario. If there's somebody with a STEMI, with spasm, with vasoconstriction, with a hematoma, you always need to put the measurements you do in perspective. If you measure a 2.5 millimeter vessel and approximate LAD of a 50-year-old male, then there is something wrong. And this can typically not be the case. So these vessels, you need to use your common sense when interpreting the IVUS measurements.
Now here's the result, and they placed a stent in here. And it looks, if I look in here, I don't see any edge sections.
So this is nice. So this stent expansion is really nice because it is almost identical to the distal reference lumen area, as you can see. You see, that's very nice transition. So not like in the previous case where you landed in the plaque and it was under expansion. Here, the stent was nicely ending in a healthy reference segment, as it should be.
Now we see.
So this is a trio stent, post-dilated with a 3.5 balloon.
Look at this. This is what you want to see in here. And if we continue it, and now you see here, this behind the stent, this the media, this is the blown up adventitia. So that has nothing to do with endo expansion. The position is exactly where you want to have it against the intima. And you see the media in here. And believe me, if we're going to do after a couple of months to repeat the IVUS, you will see that this is completely resolved and we have a normal adventitia in there. And you see there, the hematoma is still there, but now you see that the stent is there. We have a good lumen.
And don't think this stent is per definition too small, because it looks much smaller than the vessel.
Yeah. It's because this is not the real vessel. The real vessel you see in here. Yeah, this has nothing to do with the real vessel. This will come back close to the media. And then what you see indeed that he covered the ostium of the LAD. There's still the hematoma. Don't worry about that. We see it nicely against close to the media, which is nice. And then we got rid of the hematoma, and there we have also a normal, almost normal, with some internal thickening left main stem.
Yep. Wow. Yeah. So that was the last case we wanted to show you.
Is there room for some questions?
Yeah, there's still room for questions. So please don't hesitate to post them in the chat box. So what we've tried to do in this webinar to make you familiar with the different types of plaque you can encounter in patients presenting with ACS, to get a little bit familiar with the different types of thrombus, and on stent sizing and thrombus adjudication can help you, but also put you in let's say uncertain position when you think about sizing. Use your common sense and use your imaging in a structured way. And that is perhaps, I think, the most important message that we can give to you. Do your pre-procedure imaging. If you see that you need a lesion preparation in whatever way, whether it's thrombectomy, balloon, rotablade, or whatsoever, repeat the imaging to see how that worked out. Then, only then do your sizing, pick healthy reference segments, position your stent, and then look at the final result based on the 3 key criteria: edges, plaque burden less than 50%, no relevant edge dissections, and expansion of 90% of the distal healthy reference lumen area or with a minimal stent area of 5. And then your patient will have the lowest risk of future adverse cardiovascular events. So if there are no more questions, I would like to thank Jurgen again for his great
Always
input.
a pleasure, no?
I would like to thank ACIST for making this happen, and there are more webinars planned for the fall this year. And I would like to thank our AV team for their excellent support in making this happen again. Thank you very much, and enjoy the rest of the day.
Yeah.